burn management. Dr. Ali?
Hi, thank you so much, Ashley. I mean, you put the ground so high that now I'm even ashamed to be here. But thank you so much. Thanks everyone for joining us. And I'm very pleased to be able to actually talk to you guys on this webinar on the really the dressing change that's been the standard of care in our unit. I trained, as Ashley was saying, I trained in Toronto. And throughout my practice in the past 10 years, I've seen, and all of us, we've seen a lot of different type of dressing. We used to use a lot of, back when I was a student resident, we used to even use a lot of gelone, the vasinated sheets, mesh. In Toronto, we used to use a lot of flamazine and other silver dressings, Acticoat, and so on and so forth. And then throughout, even in France, a lot of iodinated mesh we used to use. And then from there on, even in our unit, we went through all these evolution through years because, as you can imagine, everybody comes in different expertise and different experience, and different products get introduced. And to be honest, this is our go-to in the past 4 to 5 years. And I'm very happy to share some of our results because I do believe our patient care had improved, our patient comfort has really improved, and it does have a substantial effect in the duration of the admission, the complication, and the reoperation, or even going to the operating room, since we've been doing these protocols and these dressings in our unit. And hence, that's why I really vouch for the product, because I do see and I do believe in it, that it has changed our practice in our unit. Sorry, let me just go here. Perfect. So tonight we'll talk first on some of the clinical evidence on the use of the pure hypochlorous acid, or the Vashe or Vash, the TLC-Ag, also known as UrgoTul Ag, with silver as a contact layer in burn management and some complex wounds. We'll review the burn care protocol that we've been doing at the CHU at the University of Montreal for the past, which is the regional burn center for covering about 65 to 70% of Quebec population in the past 4 to 5 years, and how it's evolved through the time. We'll discuss some of the outcome we've had with combination of really the Vashe, or the pure hypochlorous acid, and ErgoTul, or the TLC-Ag, in our unit. To start off, we'll talk about the pure hypochlorous acid, or Vashe. So as many of us know, it's interesting that the wound, even though it's one of the most common pathology that we deal with, is still there's not a standardized practice to prevent infection from invading pathogen. We do have a lot of different guidelines for the ventilation assisted infections, for SSI, for the catheter associated infections, or the bladder associated infection for catheterization, but yet we're still missing a clear guideline. What is the best type of treatment for wound and non-intact skin, and how to manage it many times? And despite, as I said, it's one of the most common issue that we're dealing with, there's not a real clear guidelines. We all know many of different solutions that we've had in our practice and we use day to day. Dakin is, we used to use a lot of it in Toronto. So hypochlorite sodium, which is a very, as you know, alkaline solution, pH of 9, almost 8.5, 9, depending on the percentage you're using. As you know, it is not really safe. It is cytotoxic. It is, however, efficacious for sure. It kills a lot of things. And there's not really a lot of guidelines in regards with Dakin solution. Saline solution, physiological saline, of course, is safe. The pH is close to the skin, about pH of 5.5, 6, which is the skin pH. However, it is not very efficacious for treating infection or treating the biofilm. Chlorhexidine, again, another solution. We use it all the time in the operating room. Again, not safe, cytotoxic. It is very efficacious, but again, not the pH of the skin, which we'll talk about the importance of the skin pH later on through the talk. Acetic acid, we use it quite often for Pseudomonas, again, cytotoxic. Hence, it can be effective, but it does prevent fibroblast proliferation and wound healing. And last, PHMB, again, similar thing. It is efficacious. However, again, the pH is not the physiological pH, and there are many studies showing some cytotoxicity with it. And these are some of the common, of course, we use. Again, in multiple studies, We're not going to go in details to it, but this lack that there is no real evidence on what is the best treatment for the wound management exists in multiple peer review studies that have been published through years. What is the recommendation of the International Wound Infection Institute? It's almost a no-brainer. So they recommend to use always to clean the wound, to also pay attention to the pre-wound and the wound edges to get a therapeutic cleansing of the wound. And so if you go into details about what the current recommendation is, they recommend, of course, every time to cleanse the wound with an inert solution because we don't want to have a cytotoxic product all the time applied to the wound. It can, of course, cause damage to the fibroblast and prevent healing. We want to have a solution that can disrupt the biofilm. Biofilm, as we all know, is the culprit of a lot of these chronic wounds. And as we know, saline, of course, which is the most common solution that we do use in outpatient or inpatient many times, is not very effective for damaging or disrupting the biofilm. We want to have the cleaning solution that can protect, of course, the pre-wound. So to really not damage the healthy skin around the wound. It is important, as you know, that these chronic wounds to absorb that MMP, a lot of these harmful enzymes that are being secreted through these chronic wounds, and a lot of it can damage the pre-wound. So whatever dressing we use, ideally, is to actually collect or to contain some of these harmful enzymes. Of course, using an antiseptic solution is much superior in terms of reducing the bacterial load compared to normal saline. And also, again, don't forget that the pre-wounds should be protected, and still the frequency of dressing change has not really been established. What is the ideal frequency change? And all of us, according to our experience and knowledge, we have different protocols in terms of wound dressing change. One thing is clear, of course, that when we're using an antiseptic solution compared to a non-antiseptic could be a surfactant plus saline, for example, soap and water that many times we use to wash off the wound, it is inferior. So when we're using antiseptic, you actually lead to much more substantial, greater reduction of the bacterial load in the wound. Many times, again, as I said, even in replant, I do quite a bit of replant upper extremity, and many times we used to always wash it with, under the sink water with soap, with regular soap, and rub it, and still we do get quite a bit of infection. And me, myself, personally, I've really shied away from it, and I use a lot of iodine, which is still not the ideal solution, but at least given the whole thing, and this is mainly before the Vashe, I think it decreases the chance of infection much more than compare using the soap. So how do we select the best antiseptic cleanser? You want to have, as we talked about, something that's not cytotoxic to be able to debride the tissue ideally and to have a physiological pH of the skin. pH of the skin is about 5.5. So you want to have something not too alkaline because alkaline pH does damage the skin, does cause chronic wound. And I'll have a slide on it that will explain a bit more. And having the antiseptic solution really have, again, multiple studies shown that it can decrease the viral load or the bacterial load on the wound bed. Unfortunately, there are a lot of evidence missing in terms of management of the wounds. The ability of saline, we all know, in terms of managing high levels of microbes is very limited. We do need a cleanser solution to remove or disrupt the biofilm. And the ideal solution should be balanced in terms of removal of biofilm and at the same time not to damage the good cells, the healing cells, the fibroblasts. Many of these solutions that we briefly talked about, hydrogen peroxide, sodium hypochlorite, Dakin solution, iodine, a bit less, but all chlorhexidine, all proven to be really cytotoxic. So we're looking for that, magic solution. And I think, as you'll see, the hypochlorous acid could be the answer. A pure hypochlorous acid, and that should be pure because the pH varies according to purity of the hypochlorous acid, is safe. It is efficacious, and we'll go through the data. The pH is the ideal pH of skin healing, which is about 5.5. And there are multiple guidelines. So the hypochlorous and hypochlorite both are potent antimicrobial. However, hypochlorite, as we talked about Dakin, is quite cytotoxic, and the hypochlorous has a much higher therapeutic index. At the same time, the solution, interestingly, you'll see some examples, it can be really used as a standalone debridement agent, or it can be combined with other modalities, such as the negative pressure wound therapy with installation. So what is hypochlorous acid? Hypochlorous acid is really what our body is using to fight pathogens. Every time the neutrophils go to the pathogen, they engulf, they produce hypochlorous acid within the neutrophil, they destroy the pathogen, and they secrete it. So that product has been really extracted in the lab and has been used as pure hypochlorous acid in these blue bottles. So really you have the neutrophil juice inside the bottle. And I think this is the most important slide in the talk, because as you can see here, anything, as long as it's not a biofilm, in contact with the Vashe solution or pure hypochlorous acid, dies within 15 seconds. It can be anything from the fungus, spores, viruses, or even all the multi-drug resistant bacteria, MRSA, VRE, Pseudomonas, of course. And as you can see, anything more than 99.9% is basically destroyed within 15 seconds. Let me see if I can move. Sorry, this. So pure hypochlorous acid has the ability to disrupt the biofilm after a very short exposure. And what is that exposure? Anything between 3 to 10 minutes. And I think that's part of the reason that, as you will see in our protocol, we really apply that hypochlorous acid Vashe solution to our wound bed about 10 minutes. And there is no known clinical relevant resistance up to now known that the Vashe cannot work against. So it's really, there's no resistance up to now for the pure hypochlorous acid. It is proven to be safe from head to toe. You can apply it to the cornea, mucosa, you can apply it to genital area, to the catheter. So there's really no contraindication. You can wash off the eye with it. Looking at the survival of the fibroblasts and keratinocytes, anything more than 75% survival, we say it is not cytotoxic, and it's much higher than 75. But as you can see, only saline and hypochlorous acid has passed the test of having survival upon exposure to the fibroblasts and keratinocyte. Talking about the pH, the normal skin pH you can actually see is about 5.5, and hypochlorous acid is really within that range. So a healthy intact skin is acidic. It is acidic because it has some antimicrobial properties. It favors the wound healing. It preserves the skin function. It increases the macrophage and the fibroblast activity within that pH. And the stratum corneum is more cohesive. It's more of a barrier function. Once you get into the chronic wound stage, and this is where you start getting alkaline, you get an alkaline environment. That is actually has been shown that the pathogens can thrive within, decreases healing, it causes inflammation, and hence that's not ideal for the wound. Maybe you do kill the bugs in the wound, but it's not ideal for wound healing. Vashe has been, or pure hypochlorous acid, has many studies has been published, many peer-reviewed studies, been around in Canada for about 7-8 years, and in the world about 10 years. The studies have looked at various pathologies. We're dealing mainly with the complex wound in our center, but as you can see, it can be used through the studies on venous leg ulcers, diabetic foot, pre or post debridement, complex wound being either pressure injuries, trauma, burn, which were the main topic of tonight, graft, both on the graft side and of course the donor side, safe on pediatric patients, can be used for even damaged skin, macerated with, macerated skin or the irritated skin. Sorry. And try to go skin tears or even post-surgical incision infections, stomatitis, central lines, G-tube, and trachs. Some of the examples provided to me by the company, you can actually see, for example, pediatric burn using Vashe really avoids infection, fights everything, dries up really at the same time, allowing the fibroblast to really proliferate. And you can see on a fragile pediatric skin, goes to almost complete healing fast within 19 days. It's all epithelialized, and of course at day 30. An example for the pressure injuries, again, as we talked about, it really debrides the solution. So by just applying the soaked Vashe solution, you can actually see all the fibrin being removed from a pressure ulcer. Pediatric, I was just talking about, I have two kids, so I'm always concerned about what goes on their skin and what they do and so on and so forth. So, and it's been shown it's quite safe in the pediatric population. It's really the solution existing in our neutrophil. So it has a broad spectrum of antibacterial effect. Again, there is no known resistance, and it's quite effective against even biofilm. Within 10 minutes, it really destroys the biofilm. It is non-toxic to the healthy skin, promotes wound healing, as opposed to a lot of other cytotoxic solutions. It's non-irritating. It has almost no side effect. We've never seen a patient having pain on application or really suffering through the application of the solution, and it is quite effective. Now, second part of the talk, we're gonna talk about the wound dressing that we apply aside. So the Vashe is the solution a lot of times we deal with as we're getting infected, as we're actually washing off the original patients coming in, as we're dealing with biofilm. If really it's our go-to solution once nothing else works. So once we see something is being either too gluey, biofilmy, something that's looking infected, we really try the Vashe to try to dry it up, or at the same time control the infection, being a soak, being irrigation solution through the negative pressure therapy, or any sort of application. And I'll talk about some examples. Second part of the talk is really about our contact layer on the wound, what we actually use 99% of the time on a burn unit, being a small or large size. And that is the TLC-Ag. So the tissue lipid colloid dressing, or UrgoTul. We do need, what is an ideal dressing for the wound? So you want a dressing that is a barrier to bacteria, of course. You want a dressing that has some antibacterial efficacy to decrease the risk of infection. To control the moisture, ideally, so you don't want to have too much liquid around in the wound and the peri-wound to get damaged, and to promote healing. To avoid trauma, and I think pain is a big thing in our patients, as you all know. These dressing changes, we've had many patients, even post being grafted, is still, if they're too painful for the dressing change, we have to keep them, do dressing under sedation. So if you do find the dressing that's really is tolerable on a patient, it affects quite a bit their care. Many studies have shown that having a traumatic wound care dressing delays wound healing process. It actually increases or should say decrease the immune function, and can lead, of course, as you can imagine, to post-traumatic stress disorder, and in pediatrics, behavioral problems. And of course, we want to have a dressing which has some evidence behind it. Currently, majority of the non-adherent contact dressings, they unfortunately decrease the healing. So yes, it's true, many of them, they're tolerable still to the patient, but majority of them have been shown to decrease the wound proliferation of the fibroblasts. Many of them even have been shown to be cytotoxic or ineffective. They can cause sometimes pain, trauma during the dressing change, or even increase the chance of course, infection, depending on the frequency of change and the type of dressing. And this can eventually lead to longer recovery time, extended hospital stays, or increase, of course, treatment costs. The two main non-adherent contact dressings that are used either are mesh-based, such as the Bacteria gelone and so on and so forth, or they're silicone-based. And interestingly, silicone by itself, it has a tendency to inhibit the cell growth. So majority of the silicone dressings, and I'll show you some studies, actually do decrease wound healing compared to a neutral dressing. And mesh, every time you're ripping off some keratinocytes and some fibroblasts, and it can be, of course, cytotoxic and quite painful upon dressing change. So the dressing, we want to have something that promotes healing, so allow the key cells, fibroblasts, collagen to proliferate. We don't want to have pain on the dressing change, have some antibacterial, antimicrobial effect, and of course, to have some evidence behind it. So what is a TLC? TLC dressing. TLC dressing is really the CMC, which is the base of many commonly known dressings, carboxymethylcellulose, like Duoderm, with lipophilic particles. So you have this mesh rather than being silicone base or the the paper base, the mesh base, that is really a CMC mesh, and within it is impregnated some lipophilic particles. And this is without silver. So there do exist with silver without. It promotes healing by creating a bio-friendly gel conductive for the cell health and proliferation. And as you've seen Duoderm, of course, it really upon removal, there's no pain with it associated and is non-traumatic. It is the core technology for the company actually, and they've had multiple patients treated with it. More than 50, close to 54,000 patients and 11.6 or almost 12,000 patients on studies. Comparing the UrgoTul or TLC to a traditional gauze, you can actually see upon change of dressing, there is really no damage to the keratinocytes. So this is electron microscopy, and you can see upon removing and placing it on, you've got this CMC that's really absorbing, keeping the exudate and MMPs and all that bad enzymes away from the wound. At the same time, upon dressing change, it's really easy to remove compared to the gauze that many times it disrupts. It's a mechanical debridement. Every time you're putting it on, as you're taking it off, you're taking off some fibroblasts. So it does damage some fibroblasts and also the wound bed. Now imagine we add on silver to it. So there it goes, UrgoTul Ag or the TLC-Ag. The Ag in the TLC is in an ionic form, so silver sulfate. It is impregnated within that CMC, I should say, structure. And as all of us know, silver has antimicrobial efficacy. It's been proven that this dressing can be applied to the wound bed, stay on for 7 days, and still be effective with the silver release. In our unit, we usually do dressing change every 3 to 5 days, because looking at the wound, of course, and deciding when we take the patient to the OR, if we do take the patient, but it can be left as an outpatient setting easily up to 7 days and still have the silver antimicrobial effect. It's been proven to facilitate wound progression and towards healing, of course, and reduce signs of local infection over neutral dressings. These are some of the studies looking actually at the fibroblast proliferation. As we talked about Vashe, we're looking also at the UrgoTul. So you can actually see on the left side of the screen that we're using UrgoTul, up to 70% plus of the fibroblasts is still proliferate. And now we're comparing it to other type of dressing. So if you look at A is really gelone. So you're looking at the mesh, which is just a vaselineated mesh type of thing. So it's almost neutral. Then you're seeing at some moderate decrease in fibroblast proliferation. That's Mepitel. Sorry. Then you have here in the black dot, greasy gauze. And that's, of course, we talked about it. Every time you're taking off some fibroblasts. So it's inhibition. And at the end, here you have adaptic, which is quite a bit of inhibiting to the wound healing. Pain management, we talked about it. It's a very easy remove dressing. You've got that really colloid structure that doesn't stick to the wound. Very easy to remove and apply to the patient. There's no pain upon application compared to, let's say, Acticoat that we all of us know. It's really can burn some patients upon application. And the studies have shown 95% of patients with acute wounds and 88% with chronic wounds reported no almost pain upon application. And it does show in this study close to 50% reduction in the wound size compared to a neutral dressing. More than almost close to 12,000 patients in different studies that have shown it is a very effective dressing to decrease infection, to protect the wound, can be used in the burn injury, acute or chronic wounds. And I think it's a very promising dressing, and we've been using it, as I said, almost on more than 98%, I should say, of our wounds as the primary dressing in all the in-house patients, and many times as in our outpatient clinic. It provides a moist, conductive environment that promotes healing process. It's really almost pain-free. and even for children has been shown to be safe and very easy to apply. This is another study looking at the infection rate using the UrgoTul Ag or the TLC-Ag with the silver. And you can actually see that it does decrease the chance of infection quite a bit substantially, up to about 80%, and the clinical signs of infection about 72%. In this study, patients, 92% went on to complete wound healing using the TLC-Ag dressing. And again, in terms of pain management, it's very tolerable. 85% found the dressing to be well tolerated. It improved the pre-wound skin in 66% of patients. And the physicians who were part of the study really rated the dressing as very useful, very good antimicrobial effect, and promote healing. Some examples, pediatric and adult. You can see on the left side, a young child, 1 year old, having a superficial thickness burn, partial thickness, that's been treated with the UrgoTul. You can see on the right top a wound, again being treated with the UrgoTul. Very easy to apply, almost, as I said, pain-free. At the bottom, you have an older lady, 96-year-old, with a pressure ulcer that has been treated with UrgoTul. So again, going on to healing up to 28 days. In terms of, in our unit, majority of times, a wound as such, really we treat it more with Vashe at the beginning and dressing with the TLC-Ag. So really we use a combination of the two all pretty much in almost every wound. And on the right bottom side, you can see on a donor site and the grafted site using the TLC-Ag. It improves the wound bed, promotes granulation tissue, reduces signs of infection, and reduces the wound area. Almost pain-free and atraumatic to the patients. And due to the non-adhesive nature of the dressing, this really can be recommended, of course, for patients with fragile pre-wound skin, because really applying and taking off, it's not like Acticoat or other dressing that really sticks to the wound. And it can be left, as we talked about, up to 7 days with evidence that is still the effect of the silver is active and it still has enough power to absorb the exudate from the wound, not to damage the skin and make it macerated. So what is our protocol in our burn unit in Montreal? Any patient that gets admitted, and this is really for the past 4 to 5 years we've been doing this, we wash them off with warm Vashe. The solution, the hypochlorous acid, can be warmed up to about 109 degrees Fahrenheit. We warm it, we put it in the, sorry, we put it in the warmer at 40 degrees. And so it's really warm, easy to apply on patients. They don't get hypothermic. And we put these soaks really dressings on the patient, leave them off for about 10 minutes, and we make sure that really it's soaked throughout the time. And then after we start debriding the wounds, any blisters and so on and so forth, we assess the TBSA, and then we apply the UrgoTul Ag with the dry sponge on the patient. So on the side table, the nurses, they prepare all these big sheets with the the burn dressings, staple them to the burn dressing, and as soon as all the cleaning up is done with the Vashe, TBSA assessed, the lines are in, you apply it, and there you go, that's your dressing. And that can stay up to 7 days if you're planning to. So let's say if you have a patient in the clinic and you want to see them on a weekly basis, you can actually apply this dressing, have them come back once a week. We do, as I said, many of them in-house patients, these type of dressings, and sometimes outside, but we apply it, and we usually assess them every 3 days or so, because deciding if we're going to the OR or not. The dressing is changed every 3 to 4 days. We reassess the wound for the grafting. And important to note that the first dressing change, sometimes you do get this biofilm looking of shape onto the wound. And I think a lot of it is because of that CMC. It's really absorbing that liquid. Some of it, it's really, you see, once you apply and remove it, it's very easy to apply and remove. And if it gives us that structure, we just wash it off again with Vashe. We clean it up. Again, usually always heat it, Vashe solution, about 10, 15 to 20 minutes, depending on the patient. And we apply again new dressing if we're planning not to go to the OR and let it heal by itself. and or if the surgery, let's say, if it's done in 3-4 days. If not, we'll just go into the other less expensive sometimes dressings if the surgery is going to be done, let's say, the day after. Facial burn care. So same thing. Vash is the solution we use majority of times with Vaseline on the second degrees that we're thinking it's going to heal. Apply it for about 15 to 20 minutes every 6 hours. Really, it avoids infection, dries up, kills the biofilm, and we apply the Vaseline on top afterwards. If it's a third degree burn or deeper, we apply a lot of times the collagenous Santil with the Vash solution, trying to debride until we decide if we're going to operate on the patient or not for facial grafting. And in areas such as, the posterior ear, postauricular, and so on and so forth, to avoid the peanut to attach to the mastid and so on and so forth, we apply the UrgoTul Ag basically as a dressing of choice. Hand burn, similar. We wash, as I said, all the burns with Vash. Then we apply dressing. For the hand, UrgoTul Ag, direct onto the wound without a gauze, with just a clink in 2-inch or 3-inch. And you can moisten it with distilled water, you can moisten it with saline, and really this way you have a very light dressing, fingers separated, and they can actually go through their exercises as they need to. Negative wound pressure therapy, a lot of complex wounds. And in our center, we do treat both. We do treat the large size burns and, of course, the complex wounds from anybody, from even a lot of academic centers that they send to us. So again, for the complex wounds being either with installation therapy or not, the interface is majority of times UrgoTul Ag. And we again wrap it around the gauze, and this way it's already cut to size, applied to the wound. It protects really the pre-wound. As we talked about, it really absorbs. You can do installation with it. If it is no installation on the graft, immediately we're applying the negative pressure therapy. We put it at minus 75 millimeter of mercury, and for about 4 days. So all the dressings we assess at 4 days, not 5, because it's traditional. Every wound dressing post-op gets done at 4 days, and that's where we decide discharge or keep a couple more days. We turn off the machine, as you all know, a couple hours before, so it's much more tolerable for the patient as we take off the sponge from the patient. And if we need to do a dressing at that stage, we can apply Vash plus the UrgoTul as needed. Things to know about Vash solution is that you cannot mix it with chlorhexidine. It causes a salt formation. So any chlorhexidine solution has to be wiped off before applying the Vash solution, because you lose the effect of pretty much both. So you rinse it with saline or still water, and then you can apply the Vash. It can be heated up, as we said, to 109 degrees Fahrenheit, 42.7 almost. We heat it up to 40 degrees because after that, it can actually damage the hypochlorous acid. You should not dilute it. We talked about it. It's a pure hypochlorous acid. Pure hypochlorous acid has this pH, which is really the skin pH, and the efficacy really decreases if you do dilute the Vash solution. And if there's a scar present, excise it before, of course, applying Vash, because sometimes it cannot soak through. I'm going to present some of the cases, example cases. And after we finish the example cases, we can actually do a question and answer type of period. So if you guys have questions, just hold on to it. I'll talk about a couple of examples and then we go on to the questions. So this is actually our sentinel case, I think, of the TLC-Ag, the UrgoTul that we used. The 40-year-old guy who was second and third degree burn, 15% TBSA. And this is him on admission. You can see on the left side, not a lot of cap refill upon the first dressing change. So we applied the TLC-Ag dressing. You leave it on for 3 days. You assess. It looks like surgical. Take him to the OR, debride, and use the TLC-Ag again with the VAC therapy. We VAC pretty much as we can. We VAC them, any patient. So upper extremity, elbow, shoulder, lower extremity, foot, commonly. The only thing we don't vac a lot is hand itself, because hand, I think it just really gets stiff with using a vac. But aside from the hand, really neck, back, and large size vacs, circumferential, sometimes the whole body. TLC-Ag, vac, they have no restriction in movement. They can walk around with the vac, zero restriction. and we take it off at 4 days, and literally the same day or the day after, usually they get discharged to our rehab center. So decreases the admission from 5 to 4 always, now we've done. And at the same time, applying a vac allows them, of course, to move around and really go through the rehab immediately. And the dressing is so tolerable to take off with the vac that really the dressing change, I think it's substantially decreased our use of narcotics or anxiolytic for the dressing changes. So the guy, as you can see, debrided, skin grafted, vac on, and of course you can see some authorized areas, but overall he did well and he was discharged within 16 days, I think 14 days or so. 16 days from the burn, for 12 days from the admission. Another case, a bit different. So polytrauma, deep wounds, 31-year-old guy, intoxicated, who had an MVA. And again, as I said, we do get a lot of complex wounds at the same time, not just burn, multiple fracture, hemopneumothorax, second, third degree, 33% TBSA burn, lower extremities, scrotum were done for the burns. And you can actually see him on admission, quite a bit deep, very deep burns, lower extremity, and quite a large surface area. Again, wash with Vashe, UrgoTul applied, and then we go through assessments of the wound. But you can see very fast how the injuries they declare quite deep, multiple debridements, but then now we have bone tendon exposed, which of course is a substantial risk of amputation given the potential donor sites and the patient's comorbidities. And you can actually see here, just by applying the Vashe and the TLC-Ag, allograft being applied, and then we go through this cycle. Whatever it actually doesn't heal, we treat it as a separate wound, installation with the Vashe, and you can see you start getting actually debriding all that necrotic tissue really through this installation therapy. You get very good granulation compared to a lot of other solutions. And basically, once you have it all covered using the installation therapy, using Vashe, as needed, we use the TLC-Ag, and off he goes to, really grafting and without any flap reconstruction to get discharged. Another case of a bit larger size burn, 56% TBSA, 64-year-old guy, diabetic, who had a thermal injury due to explosion. And he had multiple infections. And you can see of course, you can imagine what kind of admission this guy is going to have. So again, large TBSA, not good donor sites available because lower extremities are burned, the back is burned, you've got a bit of thorax and lower abdomen available as donor sites, and deep burns. So here we use meek, and this is something we've been using for the past 3 to 4 years, very often in large size burn, because it can be a lifesaver in a sense that in one surgery with minimal donor site, we expanded to 4. You can really cover amazingly a large portion of the patient. We do in 2 position. We try to really 2 teams. One team is preparing meek, one team is harvesting, and at the same time, or grafting at the same time. And really by doing this, reduce the time and just get the patient done in a reasonable time. So you can actually see here there goes meek, donor size being the buttock, a bit of the shoulders and some chest, and that's it. And we cover the whole thing. Post-op day 7, we start removing the meek sheets. And here you can see the result. These are the donor sites. So you can actually see pretty good results given the meek at 4-month post-injury. And I'll talk to you about the protocol of dressing that we do for the meek. So he had some, of course, hypergranulation tissue, some contractures, as you can imagine, but at least we managed to save him with minimal surgical or return to the theater, and at the same time getting him all closed pretty fast. How do we do the dressing on the meek? So day surgery. We used to apply a lot of Acticoat at the beginning. Now we've actually shied away from the Acticoat. And the reason was Acticoat was a lot of some of my colleagues were really pro the fact that, maybe Acticoat has more of a silver release to really avoid having infection, especially having a widely graft skin, sorry. But now we don't do much of Acticoat, but this is the protocol we used to do. And we apply a lot of Vashe now. So really day zero, we do Vashe plus the UrgoTul. We do the first dressing change, and we've gone through this protocol so many times because it's really, there's no real nice study showing what is the best regimen for the dressing change. And we used to take off the sheets up to 3 weeks. We used to leave them on, and we started seeing all maceration. Then we went back to about 5 days. Oh, it's too early. So now we do about a week, and we start trying to taking off the sheets, taking off the staples, reposition patients every 2 hours. By day 14, 2 weeks, we start really trying to take off all the sheets of the meat. And then apply the UrgoTul Ag over it with Vashe. So every dressing change we do, we apply Vashe, leave it on for 10-15 minutes, apply the UrgoTul with the dry gauze as we saw with the burn dressing. And about, after day 14, really the dressing, everything should be removed. You still go through the dry flow change every 4 hours, repositioning. And at this stage, you can start seeing if there are areas that have been between the sheets that can start causing hypergranulation. It really works amazing on the back, the areas that you have pressure on. So back, if somebody's, let's say, ARDS and so on, so prone, again, the chest, depending on the position, but less, you get more hypergranulation tissue, of course, as you can imagine, in the upper extremities or lower extremities. And I think part of it is because there's no direct pressure on those areas in between the rectangular sheets of the meat. But Vashe, dressing change, sheets come off after about a week. By 2 weeks, everything pretty much off. We go into UrgoTul and washing off with Vashe. Next Vashe, again, part of the complex wound that they come, as I said, all across the Quebec, they really send us, even from many academic centers, when they say, oh, we don't know what to do with the patient. So a young guy, 35% neck Vashe, and you can actually see quite extensive. Again, same treatment, Vashe irrigation installation with the VAC, and then going on to skin grafting. And these are some of the example of our neck Vashe patients. And you can see many of them, for example, that gentleman, as you can see, goes on to have, families and so on and so forth. So a lot of nice, really happy endings for a lot of these patients. Another case of a neck Vashe on a IV drug user, upper extremity MRSA infected. Again, installation therapy, you can see everything's exposed, tendons macerated. So we're going through from the saline to the Vashe installation, and you can see within 3 days, quite a bit of improvement in the fibrin, improvement in the wound bed, and we continue with the installation. And eventually, he was changed to saline, and I think that's part of the reason it took a bit longer by the time he got granulated, because it took him about a month to get everything covered by granulation tissue to go on to the skin coverage of a skin grafting. A young gentleman, 60% TBSA, and this is an example of the facial actually burns. He even had one of his surgeries done, with ARDS in the prone position. And you can see facial burn at 10 days, quite deep looking. And the classic protocol we used to always have was apply Vaseline at 2 weeks or 3 weeks to assess for the skin grafting. So there was a lot of hesitation for his grafting his skin through the family and himself back and forth. So we're doing these saline soaks and polysporin. And you can see at 2 months is still, this is not good. At 2 months is still, he's got all these wounds going on around, and they're refusing even the skin grafting to the face. And just switching to the Vashe, you can actually see how much improvement within 5 days he got into the, his chronic, I should say now, facial wounds. Same thing, warm to 40 degrees, comfortable to the patient, apply 4 times a day, 20 minutes, 15 minutes onto the face. And if they're deep, we apply the collagenase or the Santil with the Vaseline onto the facial burns. This is an example of not long ago, maybe about a year, 8 months ago or so, of maybe less even, a 19-year-old guy, which I think is the worst TENS I've ever seen in my career or even my training. So he had TENS, not known to add or acyclovir. And when he came into us, he even, in our protocol, Derm, of course, immediately gets involved. He got etanercept, and he got infected with multi-drug resistant Pseudomonas. And you can see quite a bit very extensive involvement of the skin. And really, this guy, he was sick. So BioBrain, Acticoat, everything we threw at him, but he was just getting infected, not getting better, very, very sick. Multiple discussion about even level of care and so on and so forth. And eventually, of course, switched to the Vashe and UrgoTul Ag. Took a long time, but eventually managed to get him healed. And you can see, honestly, it was the worst case ever of TENS you can imagine. Eventually went on to healing and discharge, but quite a bit of challenge. And I think if it wasn't really for Vashe, probably, I don't know if he would have survived, because none of the conventional dressing we always used to use for TENS was really not working. I'm going to end the talk just, for example, another case of about 15% TBSA burn, young guy who comes into admission, and you can actually see many areas you're doubtful if it's going to be surgical or not. No cap refill on good portion of the upper extremity. And using, again, the Vashe plus the UrgoTul, which I think really promotes healing compared to a conventional old dressing, you can get him completely healed with no skin grafting. And there's so many of these patients, because this example, for example, he ended up with no graft at all. But there are many patients that I think using this protocol with UrgoTul, we really managed to get a good portion of their skin healed and not requiring surgery compared to older Gelonate or other type of dressing. So in conclusion, in our protocol, we always wash them with the pure hypochlorous acid. In admission, we apply the TLC-Ag contact as the main dressing change. And if needed, it can be applied with the VAC negative pressure wound therapy or with the installation with the Vashe. Thank you so much, everyone, for listening, and I'm here to answer any questions. Let me just go back to the main screen. Thank you. So I'm going to go through the questions. If Ashley,
Yes.
sorry, do you have the questions, or is it on the chat section?
If anyone has any questions, you can take yourself off mute and you can say them out loud. I think most of them were answered. Because me and Benoit kind of tag teamed answering everyone as we went. Does anyone have any questions?
I do have a question just around the Acticoat. I might have missed a little bit what you were talking there, but did you say you're just going straight to UrgoTul now, or are you using Acticoat initially to that higher level of delivery to silver to the wound and then switching to UrgoTul?
Yeah, very good question. So, Acticoat, as you all know, it really stains the wound. You've seen it. You apply it, even the pre-wound is all looking silverish and blackish. I do not personally believe that with Acticoat you actually get much more release of the silver. It's a different type of release. We talked about it with Dr. Papp even during the CBA meeting. So Acticoat is a nanocrystal release, and it's a different type of mechanism compared to the ionic silver. So the issue is, because we all have this hypothesis, and we actually had Dr. Papp ask me the question, and I wasn't even sure at the time, and I had to go back and look up some of the studies. When you're applying Acticoat, we always say, oh, the saline. So Acticoat, because Ag and of course AgCl, it precipitates 10 to minus 17, I think, and quite a bit. So Acticoat, but what is interesting is what is effective is actually the Ag. So if you look at the cells, our cells, we all have the 70% of our solution in our body is chloride. So all the interstitial fluid has 70% of the negative charge is chloride. So as soon as you apply the Acticoat or any sort of dressing, that AgCl is formed. It doesn't matter what it is. So the fact that I think a lot of it is really this thinking that Acticoat has a lot more silver release compared to other silver dressings. I personally think it's been a lot of a stigma about it in a sense with the company trying to promote it, because when you look at closely to the studies, it doesn't show that it decreases chance of infection because it has high release of silver. It's just, immediately upon the Acticoat activation, even on the wound, you get the AgCl. Being washed with NS or the water, we always say, oh, don't touch it with NS because you're going to precipitate. But it's really the ionic silver which is active against the bacteria and not the nanocrystal silver being released. So and that was exactly the thinking we had back in the day with the MIC, that, oh, let's put Acticoat so you get more release of silver onto the wound at the beginning to avoid the infection and then change it to other solution. And unfortunately, that didn't work as well because many of these MIC with Acticoat really got, even Pseudomonas, they got really macerated looking, moist looking, biofilm looking. And that's why we went away from the Acticoat and now we're doing this UrgoTul Ag with Vashe. And I think honestly, Vashe is such an amazing solution. Anytime in our unit we have an issue, put Vashe on it. Anytime nothing works, put Vashe on it. And I think it saved us quite a bit. So between Acticoat and Vashe, I would go always with Vashe. UrgoTul, I think, is as effective in terms of silver release compared to Acticoat. I don't think really Acticoat releases much more silver compared to the ionic silver. It's just it stains the wound around, and we think, I myself for years thought, oh my God, you get so much, I guess, silver released onto the wound, at least from the appearance, but I don't think it's true. And also, even Acticoat used to say, oh, double layered to go to 7 days. The studies have shown really the silver dressing on the TLC-Ag can actually get released up to about 7 days gradually and have enough antimicrobial effect. So we don't really go much to Acticoat.
All right, awesome. Thank you.
Jacqueline Clark, I think your hand was raised.
Hi, thank you. Good evening.
Hi.
Thank you for your presentation. I think this is more of a comment rather than a question. I've been in the home care setting now for decades, and so this is quite a learning experience for the most part, especially where you talk about the initial stages of care, usually in a hospital setting, because these are quite severe burns, obviously. And so we don't ordinarily see them in the home setting, but I have been seeing Vashe prescribed for wound care more so than before. Normal saline was the go-to solution. And knowing now that this product or this solution is a step up, it's good to know, because again, we don't see clients in the severity that you would in the hospital and what initial treatments are being applied. So just wanted to say that. Thank you.
Thank you. Thanks for sharing. And I do a lot of aesthetic surgery as well. And even if I've had exposed implant, being reconstructive or aesthetic, many times I've washed them. I used to wash them with chlorhexidine, to be honest, at times. It burns the patient if it's sedation or local. And but the Vashe is it kills everything. It is on the top, you apply it to the wound, nobody feels anything. And because the pH is almost neutral, it's like an NS pH, and it's very effective. It's really it's a very good product.
Perfect. And then Mitra, I think you had a question about, is Vashe good for skin irritation with no wound for itchiness?
Yes, yeah, of course. So as I mentioned, there are studies actually on using for macerated skin. It's funny because, as I say, it really dries it up because a lot of it is biofilm, a lot of it is our maceration and so on and so forth. It really does, I always say, dry it up with the Vashe. It's not that drying it up, it just kills that biofilm and kills the bacteria and the pathogens, and it looks much healthier.
And then there was a question from Ardra. What is the effectiveness of silver sulfidide? Sorry, guys, I ruined that word. Topical creams and burns management.
So the silver what? Sorry, the flamazine, is that it?
Silver.
Yeah, exactly.
Yeah, silver sulfidine.
Yes, flamazine. Okay, we don't use it as much anymore because it causes that scar that you can't really assess the burn. So it is still many times when we get the transfers, even though we tell them, oh, just put a put anything, gelone on the dressing, send it to us. They put the flamazine, and really, unfortunately, it causes that scar that you can't assess the burn. You really have to rub it off, take it off, because you want to decide on these patients within 5 days. We take them to the OR or not. And in Toronto, we used to use it. In Toronto, we used to say, oh, it's a third degree, put it on because it doesn't matter. But a lot of these patients, as I said, honestly, with this dressing deep second, they evolve to actually getting healed within a week, 10 days. So in our unit, we recommend not ever to use it. If we get transferred, we always avoid, we tell them, please don't put flamazine on them. And because it really makes us much more a doubt if the wound is going to be surgical or not. And by the time you rub off and mechanically debride that scar on the wound because of the flamazine, I think it damages the skin at the same time. So we'd rather actually just put a, if you don't have access to, let's say, TLC-Ag or Vashe and so on and so forth, you can just put the gel on it and have them change every other day. You assess the wound much better. You can actually see, it doesn't cause that pseudo scar, and it still is protective. Yes, it's not an antibacterial effect, but it still is protective enough. Doing multiple dressing change by itself has shown to increase chance of infection. So if you do have access to the silver dressings to decrease the potential infection and the multiple dressing change, ideal. But if not, just the gelone every 2 days, I think, is better than putting this flamazine on the wound, personally.
And then for one of the last questions we'll take, and then after that we will be sending out a follow-up email to everyone. We have concerning the pigmentation, does it come back after treatment?
Pigmentation after burn, we say?
Yes. By Veronica Mulan.
So pigmentation after the burn, it takes time, and many times no. For example, that gentleman that we saw that healed, I tell him most likely no, the skin is never going to come back completely to normal. It gets better. It can take 3, 4, 5 years, but it's really no. Usually, it doesn't come completely back. A lot of these second degree, superficial, of course, first many times superficial or the superficial second majority times yes, but these extent of mid dermal, not really.